All right. Hello, everyone. My name is John O'Henry. I'm the ED physician based here in Melbourne. And one of the PEARLS team, as you know, stands for POCUS for Emergency and Acute Care and Resource Limited Settings. And we're running our monthly lecture series on the first Monday of every month. And I'm really delighted to be welcoming Dr. Francesco Taccari all the way from Rome, an ID physician. And he's going to be speaking to us on mycobacterial ultrasound. So I think that's really going to be a fascinating talk he has to bring us. Um, Dr. Taccari, he graduated in medicine and surgery in 2014. He's board certified in infectious diseases and tropical medicine since 2019 after a residency at the Catholic University of the Sacred Heart of Rome. He works as an attending physician in the ID consultancy unit and in the clinical ultrasound service of Gemelli's Hospital in Rome. And many of you might recognize his name because, along with Dr. Tom Haller, he's been bringing us interesting cases in our monthly newsletter in the ID Cases Around the World segment. And really grateful for your contribution there. So, Francesco, I like to really start these sessions just by asking, you know, tell us a little bit about yourself and what sort of brought you into the world of point of care ultrasound as a clinician yourself.
Um, Thank you, John, for the introduction. I work in Gemelli's Hospital as an infectious diseases consultant, and I do regularly ultrasound in my unit. I think ultrasound is a wonderful tool because we can do ultrasound whenever we want. We can try to answer with focus very simple answer which can guide us in the differential diagnosis, and which can we use for diagnosis and monitoring therapy, for example. So I can do whenever we can ultrasound during our visit, for example.
It's a universal shared experience across the world.
Yeah.
Look, please take it away. Now, one quick thought though, if anyone has any questions, you're very welcome to put them in the chat. Also, at the end of Francesco's lecture, we're going to turn off the recording and we can just have a casual question and answer session and chat more about this topic. All right, take it away.
Okay. Let's talk about ultrasound in mycobacterial infections, and especially the role of point-of-care ultrasound for diagnosis and monitoring mycobacterial infections. Let's start with a case of lumps in the neck and axillary. We have a 39-year-old male from Romania. And he comes to our outpatient clinic for low-grade fever and cervical and axillary swollen lymph nodes for 1 week. Lab tests show a normal white blood cell count, a mild increase in LDH and C-reactive protein, and the patient is tested positive for HIV, and his CD4 count is very low because he has 28 CD4 per microliter, and this is chest X-ray. It's quite remarkable, and we turn on ultrasound on the neck and see this very hypoechoic roundish lymph node with mild increase in vascularization. So we have a patient with HIV and very low CD4 count, with a fever or unknown origin. So we can go more into the diagnosis with the ultrasound of the abdomen, for example. And we can do a point-of-care ultrasound with the FASH protocol, and we start with the probe on epigastrium, looking for lymphadenopathies. We see in the video multiple roundish hypoechoic structures, which are epigastric lymphadenopathies. Tilting the probe toward the heart, we see mild amount of pericardial effusion. And moving to right hypochondrium, we do not see pleural effusion. Moving to the right flank, we do not see ascites in the Morrison pouch. Moving to left hypochondrium, we do not see left pleural effusion anymore, and we see a mild splenomegaly, but with convex probe it looks quite homogeneous. The spleen looks quite homogeneous. But if we use high frequency linear probe, we see very small hypoechoic ovular lesions scattered throughout the spleen parenchyma, which are spleen microabscesses. To complete the FASH, we move to the left flank, looking for ascites and in pelvis with the sixth position, and we do not see ascites anymore. So to sum up, we have a young male from Romania, so a country, an ITB burden country. The patient is an HIV positive patient with swollen lymph nodes, superficial lymph nodes, and if his chest X-ray is remarkable, and using the FASH protocol, scanning the abdomen, we see multiple lymphadenopathies in the abdomen, mild pericardial effusion, and multiple small microabscesses in the spleen. So the easiest thing to do is to stick a needle inside the axillary lymphadenopathy and sending a specimen for TB, for GeneXpert, and the lymph node ultrasound guided aspiration is positive for Mycobacterium tuberculosis. So we scanned the patient with the FASH protocol. FASH protocol is focused assessment with sonography for HIV-associated tuberculosis. A point-of-care ultrasound protocol introduced more than 10 years ago in South Africa. So an high HIV-TB co-infection burden setting. And the aim of the protocol is to look for sonographic signs of extrapulmonary tuberculosis, such as pleural, pericardial, and peritoneal effusion, epigastric, retroperitoneal, large lymph nodes, and especially spleen microabscesses. We will see how spleen microabscess is a cornerstone of FASH protocol, and the right patient for whom we have to make the FASH protocol is an HIV patient with symptoms of extrapulmonary tuberculosis, such as fever, weight loss, and so on. So we can define spleen microabscesses such an oval or round, hypoechoic, usually hypoechoic, less often hyperechoic image, a few millimeters in size, usually no more than 1 centimeter. And spleen microabscesses can usually be easily distinguished from one another, especially using high-frequency linear probe. And usually, spleen microabscesses are separated by areas of homogeneous spleen parenchyma, and we'll come back on this topic later. So there are multiple differential diagnoses for spleen microabscesses, but of course tuberculosis is the queen of spleen microabscesses. And here there are examples of microabscesses with the linear probe. You see how it's very easy to see them using linear probe. For example, in this video, we can see very tiny micronodules scattered throughout a very homogeneous spleen parenchyma. And these very tiny microabscesses can be easily missed Can you hear me?
Yes, apologies. Go for it, Francesco.
Okay. High frequency linear probe is very sensitive for the detection of spleen microabscesses. And these are our sonographic features we have to look for when we scan a patient with the FASH protocol. In FASH protocol, we have 6 positions, and in first position on epigastrium, we have to look for lymphadomegalies and pericardial effusion. In position 2 and 4, on right and left hypochondrium, we have to look for pleural effusion. And in fourth position, we have also to evaluate the spleen, both with convex, and I would suggest you to use always high frequency linear probe on the spleen for the evaluation of spleen parenchyma, because spleen microabscesses are very easily to see with the linear probe. Position 3 and 4 on right and left flank. In this position, we have to look for ascites in hepatorenal pouch and splenorenal pouch. And in 6th position, we have to look for ascites in pelvis. So let's try to make a sort of virtual FASH. We have 2 different patients. If we start the FASH protocol in the first position, we have to look for pericardial effusion. Where is pericardial effusion? In video on the left, or in the video on the right. Of course, we can see a mild amount of pericardial effusion in video on the right. In first position, we have also to look for epigastric lymphadomegalies, and in sorry, let's start the video. In the video on the right, we do not see any abnormalities, sonographic abnormalities. In the video on the left, we see multiple ovular hypoechoic structures near the liver. So in this video, we see epigastric lymphadomegalies. Position 2 and 4, we have to look for pleural effusion. And of course, it's quite easy to see in video on the left, a large amount of pleural effusion. And video on the right, we do not see pleural effusion because we have the curtain sign, which excludes pleural effusion. Fourth position, we have also to look for, we have also to evaluate the spleen parenchyma using first convex probe. In the video on the left, we see a very homogeneous spleen parenchyma, while in video on the right, we see a mottled spleen. So we see multiple tiny nodules, hypoechoic nodules scattered throughout the spleen parenchyma, which are, of course, spleen microabscesses. We can complete the evaluation of the spleen parenchyma using high-frequency linear probe, and you can easily see multiple hypoechoic nodules in spleen on the left, while in spleen on the right, we see a very homogeneous spleen parenchyma. Position 3 and 5, we have to look for ascites, and we see a mild amount of ascites near the right liver lobe in the video on the left. We do not see ascites in splenorenal pouch in video on the right. And lastly, we have to look for ascites in pelvis. In the first video, we see the prostate, we see the bladder, but we do not see ascites in video number 2. In video on the right, we see ascites near the gut loops and near the bladder. So the problem, the issue of FASH is sensitivity, of course, is sensitivity and specificity of all the sonographic features. And in these very recent meta-analysis, we analyzed sensitivity and specificity of 2 of the most relevant sonographic features of the FASH protocol, lymphadenomegalies and spleen microabscesses. And you can see how, despite a quite low sensitivity for both sonographic findings, they have very high specificity. So low sensitivity, but very high specificity, especially for spleen micronodules. So we can conclude that in the right patient, so in a patient coming from a high TB burden country, for example, such as for the patient in previous clinical case, patient from Romania, so ITB burden setting. If we have an HIV patient with symptoms of exopulmonary tuberculosis, such as fever of unknown origin, and if we make a FASH and we observe lymphadenomegalies and spleen microabscesses, TB suspicion has to rise up, and we can start therapy based on these findings, especially in a resource-limited setting. One other question could be, but we can use FASH for monitoring ultrasound findings and for monitoring the treatment of the patient. The authors of this article tried to attempt to answer this question, and they included 21 patients with HIV and extrapulmonary tuberculosis who underwent ultrasound evaluation with the FASH protocol at the diagnosis and at 1, 3, 6, and 12 months after starting anti-tuberculosis therapy. And you can see in the table how most of the sonographic features, especially effusions, resolved in 3 months after starting therapy. And most of abdominal lymphadenomegalies and spleen microabscesses resolved in 3 months. So we could conclude that in patients with persistent ultrasound findings at 3 months, an issue of non-adherence or drug resistance should be taken into account, or for example, an issue of immunoreconstitution inflammatory syndrome, Or, of course, we have to take into account alternative diagnosis for these findings. In my hospital, I have to deal also with other kind of immunosuppressed patients, such as patient transplantation, patient with rheumatic diseases, patient taking biologic drugs, chemotherapy, and so on. So in my hospital, we asked ourselves if FASH protocol can be applied in other kind of immunosuppressed patients, such as, for example, patients taking biologic drugs. So we evaluated a few patients with disseminated TB taking biologic drugs for rheumatic diseases, for example, and all the patients were scanned with the NE-FASH protocol. So a FASH protocol adding two scans, two parastellar scans on thorax in order to detect lung subpleural micronodules. And these are the results. We included only 5 patients. All of them were Italian, so a patient from a low TB burden setting. Most of them were taking anti-TNF drugs. All the patients had fever, so fever unknown origin. And if we look at the sonographic features, we see how spleen microabscesses using linear probe were observed in all the patients, in 100% of patients. And if we use only convex probe for the evaluation of the spleen, we can miss patients, we can miss microabscesses, and in this case, in this case serious, we miss one patient with spleen microabscesses using only convex probe. So again, I would recommend you to use high frequency linear probe for evaluation of spleen parenchyma if the issue is looking for spleen microabscesses. Usually spleen TB, in spleen TB we see multiple micronodules distributed in a miliary pattern, but more rarely we can observe larger abscesses, such as in this case. So not only microabscesses, but sometimes larger abscesses. Let's have a look at this case, another case of a lump in the neck. This time is a 31-year-old male from Brazil, living in Italy for 10 years. In February 2018, he was diagnosed with HIV with a very low CD4 count, 2 CD4 per microliter, and a pneumocystis jirovecii pneumonia. As you can see in the chest X-ray in February 2018, we see bilateral interstitial infiltrates typical of pneumocystis jirovecii pneumonia. It started out in February 2018, and it takes regularly out. In June 2018, it comes to our outpatient clinic for 2-week history of left cervical swelling and productive cough. And this is the picture of the patient in June 2018. Lab tests show mild anemia, mild thrombocytosis, but a normal white blood cell count. In June, his CD4 have increased from 2 to 260. So his immune system is restored. His HIV viremia is undetectable, and lab examination are quite remarkable. So we have a lump in the neck. First thing we can do is an ultrasound of the neck, and this is the video of the ultrasound. We see an hypoechoic, a large hypoechoic image near a vessel, probably the carotid, external carotid. And we see inside the images, the black images, we see tiny debris which are pulsing with the carotid pulse. So we can conclude that inside this lesion there is something fluid. So we can conclude that this a fluid collection, probably an abscess or a large necrotic lymphanomegaly. If we use color Doppler, we do not see vascular signals inside it. If we move to the spleen, we see a mild splenomegaly, and using high-frequency linear probe, we see multiple hypoechoic micronodules scattered throughout spleen parenchyma. If we look at the chest X-ray in June, we see how lung infiltrates are disappeared, but the mediastinal shadow is increased. So probably there are multiple. There is something wrong in the mediastinum, and probably there are multiple lymphadenogalies in the mediastinum. So which can be the diagnosis of this patient. We have a patient with HIV, with very low CD4 at the diagnosis, and after starting therapy, after a few months, he restores CD4 count, and he develops fever and multiple lymphadenogalies, superficial lymphadenogalies, and lymphomegalies in the mediastinum. So in a patient with HIV and restoration of the immune system, if the patient develops fever and lymphadenogalies, we have to suspect immune reconstitution inflammatory syndrome. And immune reconstitution inflammatory syndrome, or IRIS, can be due to opportunistic infection, such as on the top of the list, tuberculosis, non-tuberculous mycobacteria, so NTM, and endemic mycosis more rarely. These are some nice slices, some CT slices. The first slice on the neck, we see the large collection, hypodense necrotic collection in the neck. We see multiple nodules and micronodules in the lung, in a trim bud pattern distribution. We see multiple, in these slides, we see multiple necrotic lymphadenogalies in the mediastinum, and in the last slides, we see multiple micronodules in the spleen. So again, the easiest thing we can do is to stick a needle inside the large collection in the neck and sending a specimen for GeneXpert. GeneXpert is negative, but PCR for Mycobacterium avium complex is positive. So the patient, the final diagnosis of this patient is unmasked immune reconstitution inflammatory syndrome due to disseminated Mycobacterium avium complex infection. And I would like to talk to you about non-tuberculous Mycobacteria because sonographic data for NTM disseminated infection are poor, and NTM infection can be a cause of spleen micronodules. In these videos, we see with the linear probe multiple hypocortical micronodules in the spleen, which are indistinguishable from the TB ones. And when we have to suspect NTM infection, of course, in an HIV patient with a very low CD4 count, we have to suspect disseminated NTM infection. In an HIV patient taking antiretroviral therapy who develops immunoreconstitution inflammatory syndrome. So when he develops fever unknown origin, and lymphadenomegalies, superficial and abdominal or mediastinal lymphomegalies. If the patient develops arthritis, for example, and we have to suspect disseminated NTM infection. If we scanning the patient, we observe multiple and conglomerated abdominal lymphadenomegalies. And talking about the spleen microabscesses, I would say that spleen microabscesses in disseminated in NTM infection in the literature are rarely reported, but data are mainly based on CT scan and are quite old. So we asked ourselves if we can have more data on a patient with NTM disseminated infection, more data, more sonographic data in a patient with NTM disseminated infection, and we make the Pocahontas study, which is a retrospective cohort multicenter observational study, including 2 Italian, 3 African, and 1 United States centers. And we included patients with HIV infection and NTM culture-proven NTM disseminated infection. And all the patients were scanned with the FASH protocol in order to look for sonographic signs of sonographic abnormal signs. And these are the results of our study. We included 20 patients, most of them from high TB burden country, and this is, in my opinion, this is noteworthy because in ITB burden country, the first diagnosis in patient with fever, HIV, is of course TB, but we have to pay attention to NTM infection in rhesus limited setting, we do not have tests for diagnosis of an NTM infection, so we have to pay attention to this differential diagnosis for example, for spleen microabscesses. And you can see how the median CD4 count at the diagnosis was very low. And if we look at the sonographic features, we see we saw splenomegaly in 60% of patients, and in using linear probe on the spleen, we see microabscesses in 50% of patients. But again, using only a convex probe, we missed almost 20% of patients with spleen microabscesses. So again, use always linear probe for evaluation of spleen microabscesses, and abdominal lymphadenomegalies were seen in almost all the patients. And again, another question we made to ourselves was, so our feeling is that high frequency linear probe has a very high sensitivity for the detection of spleen microabscesses, and we tried to compare the diagnostic yields of high frequency linear probe and contrast-enhanced CT scan for the detection of spleen microabscesses in this small study, retrospective observational study in our hospital. We evaluated patients with cultural confirmed TB or NTM disseminated infection who underwent both contrast-enhanced CT scan and POCUS with FASH protocol using high-frequency linear probe of the spleen. And the aims of the study were to evaluate the diagnostic yields of CT and POCUS for the detection of spleen microabscesses and to determine the POCUS integrator reliability, showing clips recorded previously to a second ID physician and to 7 clinical officers with on-the-job POCUS training working in our Malawian HIV/TB clinic, so high TB burden, high HIV/TB burden setting. And these are the results. We included 29 patients, most of them had TB, and 50% were HIV co-infected. We detected spleen microabscesses in 70% of patients. And noteworthy, while POCUS detected all 20 patients with spleen microabscesses, contrast-enhanced CT detected small microabscesses only in 80% of patients, missing 20% of spleen microabscesses. If we look at the table, we see how no patient with negative POCUS have a positive CT scan, and 4 patients with a positive POCUS had a negative CT scan. So we could conclude, despite the small sample size and the retrospective nature of the study, we could conclude that spleen we can conclude that high-frequency linear probe has a comparable diagnostic yield, the diagnostic power to CT scan 1, and possibly even superior. Talking about the second aim of the study, POCUS inter-rater agreement was almost perfect between the 2 ID physicians, 2 ID physician trained to FASH, and the agreement was very high among not so expert clinical officers. This is another important thing, in my opinion. We talked about spleen microabscesses, and we talked about tuberculosis and NTM infection, but the list of differential diagnoses for spleen microabscesses is long, and there are other infectious diseases causes such as fungal abscesses, Bartonellosis, brucellosis, melioidosis, visceral leishmaniasis, but we had to include also malignancies such as Kaposi sarcoma or lymphoma, for example. And I'll talk about the differential diagnosis of spleen microabscesses briefly. Bartonellosis, for example, in Bartonellosis, hepatosplenic involvement is well reported in both in immunocompetent and immunocompromised patients, and usually spleen microabscesses are hypoechoic and usually associated with abdominal lymphadenomegalies and hypoechoic liver nodules, such as in this case we see with convex and linear probe few nodular structure, hypoechoic nodular structures in the spleen, and also in the liver. In the liver, we see multiple hypoechoic nodules. And remember, in AIDS patients, if we see multiple purplish skin lesions and multiple hypoechoic micronodules in the liver and in the spleen, we have to suspect bacillary angiomatosis, so disseminated Bartonella infection, such as in this case report, I would suggest you to read. In visual leishmaniasis, remember, we have to include visual leishmaniasis in the diagnostic, in differential diagnosis, of course, according to geographic distribution. Splenomegaly is almost is seen in almost all the patients. The same is for abdominal lymphomegalies, while focal spleen lesions are heterogeneously reported according to different case series. In my experience, for example, I have never seen focal spleen lesions in visual leishmaniasis, but in the literature are described. Again, we have to suspect Bartonellosis according to geographic distribution, and despite hepatosplenomegaly is quite common, brucellosis, focal spleen liver abscesses are uncommon. And in the literature, two different sonographic patterns are described for focal spleen and liver lesions. The solidally abscess with calcification pattern, so a large hypoechoic abscess with the central calcification is described for liver involvement, for example. So if we have a large abscess in Bartonellosis, it's usually a large abscess with a central calcification in the liver. And the second pattern described is the miliary pattern, usually seen in the spleen. So again, multiple hypoechoic micronodules scattered throughout the spleen parenchyma, such as in this picture. Another bacterial infection is melioidosis, and probably you know melioidosis better than me. And the spleen is the most common affected visceral organ in melioidosis, and ultrasound may shows hypoechoic lesions in the spleen and in the liver. And if we have a large abscess in the liver or in the spleen, a necklace or honeycomb or cartwheel appearance is described, such as in this video and picture. And to conclude the differential diagnosis, remember malignancies for spleen micronodules. Of course, in an HIV patient, we have to take into account Kaposi sarcoma and lymphoma. Kaposi sarcoma is usually associated with pathognomonic skin lesions, and Kaposi sarcoma involvement of the spleen. In Kaposi sarcoma involvement of the spleen, we usually have hypoechoic lesions, so no hypoechoic lesions, but hypoechoic lesions, sometimes small lesions with a miliary distribution, more often larger hypoechoic lesions with mass effect. In lymphoma, we can have hypoechoic small micronodules in the spleen, but more often we have large lesions with mass effect, very hypoechoic with internal vascular signals. The last topic I want to talk about is the sponge pattern. The sponge pattern is a strange pattern we have observed, me and Tom have observed evaluating the spleen of HIV patient with the linear probe, high frequency linear probe. And this is an example. In sponge pattern, we see multiple very tiny lesions, hypoechoic lesions, 1.5 to 2 millimeters in size. scattered throughout the spleen parenchyma. Sometimes they have a branching reticulonodular distribution. Sometimes they have a linear appearance, and they are quite indistinguishable one from each other, as we can see in a sponge. So the name of the pattern is sponge pattern for this. If we take a look at histology, sonographic findings in sponge patterns seem to mirror the anatomic distribution of the white pulp. We hypothesized that sponge pattern seems to mirror an hyperactivation of the white pulp, so an hyperactivation of a spleen during an infection or during an infection such as HIV, or during an opportunistic infection during HIV, or during a malignancy, for example, such as in Kaposi sarcoma, because we have observed this pattern mostly in patients with the Kaposi sarcoma. We do not exactly know if sponge pattern is pathological, or if it's a physiological variant of an homogeneous spleen. But I would like to talk about the sponge pattern because it can be easily missed for spleen microabscesses. So this is the table of patients we have described with sponge pattern. All patients were HIV. Most of them had Kaposi sarcoma, but also other opportunistic infections and malignancies. But in some cases, there were only HIV. They had only HIV infection without other co-infections or malignancies. And the issue is how we can distinguish sponge and microabscesses. There are two clips. In the first clip, we have a sponge pattern. In the second clip, we have a spleen microabscesses. If we see multiple tiny hypoechoic lesions, very tiny lesions, we cannot distinguish one from each other, such as we can see in a sponge. We have to think of sponge pattern. If we see multiple nodules, hypoechoic nodules, and we can distinguish one nodule from each other, and nodules are separated by areas of homogeneous spleen parenchyma, like a slice of Swiss cheese, we have to think of spleen microabscesses. So to conclude, if we look at the spleen and the spleen looks like a sponge, think of the sponge pattern. If we look at the spleen and the spleen looks like a Swiss cheese, think of microabscesses. And with the sponge pattern, I have concluded my lecture, and I truly thank you all for inviting me, and thank you for your attention.